And now, so from a studies point of kind of value pluralism, the idea is that when public health agencies are thinking about employing interventions for a public health problem, they're supposed to, from an ethics point of view, strike a balance between competing values. And most public health agencies think of maximising or at least improving health and well-being as their major value they're trying to achieve. But there's limits on how much they should do to promote health, and what some of those limits are ethical limits, and one limit is how much liberty restriction it might require to promote health, and how much health interventions might produce inequitable outcomes or treat people unfairly and so on. So we're striking a balance between different ethical values. And in public health ethics, the number of, hopefully I'm going to be able to advance. A number of principles have been developed to help policymakers strike an appropriate balance. And one is proportionality. And the basic idea is that the benefits of intervention are supposed to outweigh the harms, but because they can't all be measured on the same scale, that kind of requires judgments informed by data, but ethical reasoning as well. And another key principle is the least restrictive alternative, the idea that for any given amount of benefit we could get from a different set of policy options, we should choose the policy option that has similar benefits but less restriction of individual freedom. And people often think about privacy as freedom to decide about your individual health data, and so we should choose the least privacy infringing option, basically. One of the issues is that most people in public health haven't heard of public health ethics, and where they have heard of it, they don't have a kind of system for it. It's totally different to research ethics, where in research ethics we've got these well-described systems. Sure, they may not be well-funded or whatever, but at least it's its way and it's clear what the kind of requirements are. In public health ethics, even if people have heard of it, there's no system for it in almost every health department around the world. This is a editorial by Amy Fairchild in New York, talking about how in America there's very, very little public health ethics going on in public health departments, and in Australia it's kind of pretty similar. WHO, so now moving to surveillance, WHO issued what's a pretty good document really, and Amy Fairchild, the same person, was the key author for this. In 2017, I was a PhD student at the Monash Bioethics Centre doing my Monash WHO internship. And one of the interesting things about this document is that rather than thinking about ethics as kind of finding problems with scientific research or public health action, they argued that there's a strong ethical case for public health surveillance without consent, provided that appropriate protections are in place. And the kinds of protections they talk about in the document are that there's appropriate data security, including appropriate treatment of confidential data, that there's good governance, and what that means sort of is that it's accountable and transparent. And transparency has a pretty broad definition. They think that health agencies should be transparent about the aims of surveillance, how surveillance data are going to be linked to public health actions and goals, what kinds of burdens and harms it might cause, and how the data are going to be used, as well as the rights of citizens in the context of surveillance, even if they don't have a right to refuse. But it's very different to research or even clinical medicine, where you go and you consent to your data being collected for certain uses and so on. They're well defined. In public health, your sample can be taken. You give your sample for clinical purposes. Your sample can be taken. New analyses can be run, and especially the kind of genomic analysis I'm talking about doesn't require consent, and it can reveal a lot of additional information. So on the ethics and kind of social policy side, there's been a lot of recent developments. One is that there's new and more accurate findings from public health surveillance, and there's been a massive increase in public health awareness of, for example, pathogen genomics since the recent pandemic. There's new sample types like wastewater that we're talking about just before people came in. I think there's also been a tendency towards an increase in strict public health measures. There was no word lockdown in any public health plan in 2019. And previously, public health used to think that we should not engage in restrictive public health action unless it's absolutely necessary and only for the shortest period of time. But worldwide, there's been a move towards stricter public health measures. And there's also been increasing criminalisation of infectious disease transmission in some contexts, and not just HIV. So here's some examples. It's a big competition, but one of the worst policy responses in global response to the COVID pandemic was this closure of borders to some arbitrarily selected South African nations based on the detection of the Omicron variant in South Africa and Botswana. And this was kind of stupid for multiple reasons. It was futile because, evolutionary theory will tell you that if the variant is more transmissible than others, it will quickly spread around the entire world, no matter how many borders you close. It was unjust because it involved arbitrary selection of these countries, which happen to be some of the poorest countries in the world. And it also undermines kind of future trust and collaboration in public health action. It's a really bad policy decision and very visible. Back home in Victoria, you might recall that one of the reasons why our lockdowns were so hard is that pathogen genomic data were able to show with absolute certainty that the cases in the community could all be traced back to a single policy failure within hotel quarantine. You can imagine alternative paths, right, where we didn't have the genomic data. There's community transmission, but the government couldn't really be blamed for a specific policy failure. There's just, some stuff happened. There were cases in the community we hadn't detected and so on. I think the government's response would have been quite different. Whereas if you imagine that the opposition is going to nail you on this policy failure forever, that might motivate you to have extremely stringent public health action. We all know that kind of diseases like HIV have been criminalized, but in Austria, a woman was convicted for infecting her neighbor who died of COVID-19, and genomic data played a key part in that case. And just recently in the ACT, there was a case where a man was sentenced to 12 months imprisonment for knowingly infecting someone with HSV, herpes. That's a big change. I don't think, it's been a lot of sexually transmitted infections being transmitted from people who know they're infected. Now, in that case, the genomics data weren't used, but in principle, they could be used to kind of confirm these criminal cases. So like I mentioned, there's lots of kind of benefits and harms we might want to think about weighing in the case of public health surveillance. One of the public health surveillance is supposed to be linked to public health actions that produce benefits, but it also leads to kind of knowledge benefit, more abstract knowledge benefits, like improving our knowledge of the burden and transmission of infectious diseases, informing priority setting, informing public health messaging, and so on. It can lead to changes in treatment guidelines, as well as kind of standard public health actions like isolation and quarantine, infection control measures, and so on. Has different kind of harms. The more we kind of talk about and stigmatize people for being infected or transmitting them, the worse we make stigma of infectious diseases. Surveillance almost by necessity involves significant privacy infringements, but they can be greater or lesser depending on the kind of policy option we choose. There's significant reputational risks for institutions. So if you're the hotel quarantine or you're the hospital that's shown to be linked to some outbreak of some horrible pathogen, that's a big risk for your reputation. And there's obviously negative effects from excessively stringent public health measures, as well as, for example, overtreatment. If people and clinicians become overly aware of some, resistant strain, they might overuse antibiotics, for example. There's been some big technical innovations in surveillance, and many surveillance systems around the world are increasingly using these genomic approaches, also called molecular surveillance. One that I won't talk about too much today is metagenomics, and the difference between metagenomics and standard genomic sequencing is that in standard genomic sequencing, you're just looking for one pathogen. You want to sequence someone's HIV, for example. In metagenomics, we take a sample, it's pathogen agnostic. We just run it through a genomic sequencer. It picks up all the amino acids in that sample. That means human DNA, that means pathogen DNA, that means the microbiome, anything it can find, and it spits out a result. It's a big change in the way we sequence data. And people want to use that more and more for multiple reasons. And one reason is it can help us detect novel pathogens. The idea is we might prevent the next outbreak by doing this pathogen agnostic sequencing approach. Some problems that really haven't been sorted out, some potential issues. Well, one is that it's going to generate enormous numbers of incidental findings, huge, because it's not just looking for one pathogen, can find any microbe in the sample that's given, and that can be lots of different microbes, and it's unclear about which of those findings we should feed back to individual patients, clinicians, and so on. Novel pathogen detection is something that's often linked to very strict public health measures, and they might not always be justified. I'll talk about that later on. And it might lead to some privacy issues. In principle, people could be re-identified based on their microbial fingerprint. Your microbiome is actually very closely linked to you. But also, if it unavoidably sequences human DNA, which metagenomics does, well, then there's privacy implications of human DNA. And sometimes the public health agencies might want to know what the human DNA results are. For example, if there's a human genomic risk factor for an infectious disease, for example. But mostly I want to talk about phylogenetics. So once you have large databases of the genomic sequences of people's pathogens, you can look at the family relationships between those genomic sequences, so-called phylogenetics. And that allows us to be very clear about what the source of the infection or the transmission of the infection is, the source of the epidemic, and also be very clear about questions about who infected who, much more clear than we used to be able to be. So, for example, every time there's an Ebola outbreak in Africa, the local government wants to run the genomic sequences and they want to know, is this a local strain or is it an imported strain? And part of that is used for kind of political jostling between neighboring countries about who's let their guard down in terms of Ebola control. But obviously this has got major risks because it allows us to trace outbreaks down to, say, individual hospitals or countries and trace transmission down to individuals. So major implications for kind of moralization of infectious disease transmission and mistrust from the people who we need to trust public health systems the most. I'm going to talk a little bit about that in more detail, and I'm going to use HIV as the case study because that's where most of the work has been done, but this is starting to be applied to all kinds of pathogens, including resistant bacteria, syphilis, and so on. So in the HIV case, we do this in Australia too, but a lot of the controversy has been in North America, and the reason is because people don't trust governments in North America, basically. And in North America, just like in Australia, they've adopted to eliminate local HIV transmission. So in Australia, the goal is that there'll be 0 new cases of HIV linked to transmission within Australia. In America, they call this cluster detection and response. And in the genomic, with the use of kind of genomics, what that means is they define how related a cluster of HIV transmission is based on the genomic relationships between the sequences. And they sequence every single HIV test without consent, as we do in Australia. And so that informs them for their contact tracing, and it can also inform them about what's happening to the individuals within that cluster. This led to a bit of a backlash from advocacy groups like the HIV Justice Network, who put this editorial, "We are people, not clusters." And, they're worried that when public health agencies produce maps like the one below, which is from, I think, Dallas from memory, it's very easy to trace individuals within that network once you know who one of the individuals is and so on. They're worried about people being highly identifiable due to linkage of different types of data. They're worried about assessments of directionality, like who infected who, or, directionality might inform judgments about who infected who. That might involve significant privacy infringements, that it might even involve liberty infringements because public health agencies and clinicians might want to force people to comply with HIV treatments. And there's a new injectable HIV treatment where you have to have one injection every 6 months. That's the kind of thing where public health agencies might want to physically restrain people and give them HIV treatment, which has not been the approach to HIV in the past. And so that might undermine trust in public health for reasons you might understand, all aiming at the noble goal of kind of HIV transmission reduction or elimination. And just to clarify some of these kinds of terms of art here, directionality, at least in evolutionary phylogenetics, is the idea that, well, we know that there must be one strain that's earlier in the transmission pathway than strain B, and that tells you that transmission can only have occurred in that direction. Now, that still leaves the possibility that there might be, between person A and person B, a person X who we haven't sequenced, haven't identified, and they might be in that transmission pathway. But the probability that, and when you talk to scientists about this, they say, oh, yes, but there's always some residual uncertainty or whatever. But in reality, once you sequence deep enough in a pathogen, once you have additional information like what postcode someone lives in, who their social contacts might be, and so on, and once you sequence every single positive test in your community, the uncertainty margin is very, very low. We can make very accurate judgments about who infected who. And there is an alternative. We could just look at, for example, clustering. How related is the cluster without making judgments about who infected who, without looking at phylogeny per se, without making claims about directionality. And when I say linkage, well, there's lots of different types of data we can link. We can link individual sequences to a database of sequences. So, for example, everyone who has syphilis or HIV in Victoria, that allows us to do phylogenetic analysis, look at family relationships. We can link that to individual identifiers, which happens within public health agencies. And that increases our ability to know who is who in the transmission network. It also permits looking at the geographic spread of infection across countries and internationally, so-called phylogeography. And when we link that to detailed contact tracing history about who had sex with who and so on, who was where when, our assessments of direct transmission become much more accurate. And, there might be kind of positive multipliers here. The genomic data can influence the contact tracing and vice versa, but we're getting down to very, very, very identifiable information. And public health, every public health agency in Australia has the power to do this right now. And some of them do it, and they don't always tell us when they're doing it. And that leads to these kind of worries, like in this qualitative study by a colleague of mine, that at some point public health agencies could knock on someone's door and say, from the data, it looks like you're infecting a lot of people and we need you to stop doing that. And if you won't stop doing that, we'll issue a public health order saying you must comply with treatment. And in Victoria, for example, there are public health orders for HIV. They're not commonly used. It's kind of 1 to 2 per year where people are required to comply with treatment. So how could we approach this? Well, the standard kind of argument in public health and public health ethics is kind of data minimalism. That's kind of the opposite to research. In research, most scientific researchers want to kind of do the maximum amount of data collection and analysis because they want to increase the scientific impact of any given set of data. Whereas in public health, we just want to have the bare minimum privacy infringement we need to achieve the public health goal. So for example, you might think there's no need to do this kind of detailed transmission mapping when we could just in Australia look at, for example, who's picking up their antiretrovirals every 30 days whenever their scripts are issued. And we just find the people who aren't picking up their scripts and we try and help them pick up their scripts. We don't necessarily need to look at who infected who. We just focus on getting people access to treatment. But what's interesting, I think, is there's different ways data minimalism might apply to these kind of novel methods. One is that we could reduce privacy infringements by limiting the number of individuals' data that are shared and linked. We could reduce the linkage between different types of data. We could, and we already do, reduce the level of detail. So we could use kind of fuzzy location data like postcode and so on. But even postcode can be pretty accurate once you've got someone's age, sex, postcode, and if not much else about them, it can very, very much limit the people to whom those identifiers might apply. But another really cool thing is that if people are going to do phylogeny, so look at transmission networks, we could reduce the duration of linkage. So if public health agencies want to answer a specific question because there's a new outbreak of a new strain, they could run the phylogeny, answer the public health question, and then delete it. As opposed to, say, systems in Canada, like in Vancouver, where each time a new person is diagnosed with HIV, they get added to the phylogeny and it's just live updated all the time. It's something that's permanent rather than ephemeral. There's lots of different ways data minimalism might play out. I think that's one interesting kind of aspect. I think next I'm going to talk about move from the kind of technical innovation of genomics and molecular surveillance and talk a bit about different sample types, so wastewater surveillance, which again is kind of active in Australia and lots of countries worldwide. It's become much more popular since COVID. And there's some interesting, distinctive features of wastewater surveillance. WHO's got an ethics guidance coming out about this, hopefully this year. It was due last year sometime. Wastewater surveillance can be used not only for infectious disease, but for a very wide range of infectious disease. Like, for example, Singapore looks for Zika virus in their wastewater surveillance to give them a kind of sign that there might be an outbreak coming. But it can also be used for non-communicable diseases like illicit drug use. Some people have been worried that, for example, they could look for medical abortion drugs, and where there's an abortion ban, that could lead to monitoring of abortion drug use. A lot of people look at the kind of these three features, that it's collective samples rather than individual samples, that it's everyone who has access to wastewater, and that it's symptom agnostic, so it can pick up both asymptomatic and symptomatic infection. And they say, well, there's a kind of nice version of wastewater surveillance where we're just getting population level data, and it allows us to, it's not mediated by access to testing, and it can help inform our priority setting. But I'll give us some examples about how it can be used to target individuals. It can also be used for international border testing. So the next time there's an outbreak on a cruise ship, you might want to test the wastewater when it comes in to predict whether those old people are going to release some new virus on your community. And there's obviously interest for not only researchers but also police, military, and espionage uses, like when they tried to track down Osama bin Laden based on the kind of vaccine, the vaccine program, right? Similarly, we could track down individuals. So say we had the DNA of an individual or their family member, we could track down an individual through wastewater sampling. And although it's often talked about it as a collective sample approach, it can be used to target individuals in small number of individuals. Like I said, we're doing it in Australia. We've been doing it for years for poliovirus. I'm not really sure what the point of the poliovirus surveillance program is in Australia, but every now and then this pops up. This was only a month ago. there's some poliovirus in the sewage, and usually it's a recently arrived traveller from overseas who's either been vaccinated recently with the oral polio vaccine or someone who's immunosuppressed and just sheds poliovirus from their vaccination for years. There's never been an outbreak of polio in Australia, but anyway, we're still measuring it. And polio was used as a use case because it spread through the bowels, and so it's easy to detect in wastewater. But now we're doing it for everything. But it's not all kind of nice and fuzzy wastewater surveillance. So in Hong Kong, it was used in COVID in 2020 and 2021, where if an individual building or sub-region of Hong Kong was shown to have a high amount of wastewater COVID, they would just draw a line around it, set up barriers, called old-fashioned cordon sanitaire, issue restrictive testing notices, and force people to be tested until the individual cases were identified. And it's not just for the People's Republic of China. The People's Republic of the United States of America did this, and primarily in college dorms for some reason. I don't know why, but multiple universities in America started doing wastewater detection on single college dorm buildings. And when they found COVID in that building, they locked down the building. They locked the college students in this building, and they forced them all to be tested until the COVID cases were found. I thought it's just another case of bizarre kind of panic around young people spreading virus to kind of others.
I mentioned it exacerbated the spread of other infectious agents in those locked up buildings.
Yeah, I'll bet it did. I think it's a really bad policy. It's not quite as bad as the Australian policy of locking poor people in public housing towers. Now, we didn't need wastewater surveillance to do that in COVID, but you can bet that in the next respiratory virus pandemic in Australia, we will be using wastewater surveillance and we will be locking down individual buildings. And the first people that it will happen to is poor people. So just to point out that kind of wastewater surveillance isn't all kind of warm and fuzzy, can definitely be used. They can start with a big sample and work their way up to individual buildings to find one person if they need to. That's part of the reason why it's of interest to kind of military and espionage as well. Last, I'm going to talk a bit about pandemic prevention. Because one of the big things people say about very privacy infringing or novel forms of public health surveillance is, we could use it to prevent the next pandemic, and if we did, the benefits would be unlimited, and so we should be willing to accept any amount of privacy infringement and risk and so on. And I'm going to give some reasons why maybe that's not so straightforward. Here's the kind of first reason is there's a basic mathematical problem, which is that most pandemics ultimately come from animals, so-called spillovers from the animal population to the human population. But there's thousands, tens of thousands of spillovers per year. So it's like 50,000 or 60,000 coronavirus spillover events per year in places where there's lots of bats, which is the purple diagram on the left. And likewise for more dangerous pathogens like Nipah, there's little outbreaks in Bangladesh, little spillovers in Bangladesh all the time. But luckily, most of them don't become outbreaks. Most outbreaks don't become epidemics, and most epidemics don't become pandemics. And the question is, how is surveillance going to tell us the difference between the virus that's going to cause the next pandemic? This isn't looking for a needle in a haystack. It's looking for a needle in a needle stack, right? Where everything looks like a potential pandemic. And the more data we have, the more worried we'll be. And just to give you some evidence about how prevalent spillovers are, well, after the first SARS outbreak in 2003, they did serology in market workers in China, and they found 40% of them seem to have been exposed to novel coronaviruses in the past, suggesting that this kind of spillovers occurring all the time. And the problem is that, as Maria Vankakova from WHO pointed out, countries don't want to find the next pandemic. And the reason they don't want to find it is because they know that they'll have their borders closed, they'll have trade and mobility decreased. And it's really not in their interest to find that or share the data, especially if they're a poor country who can't rely on other people to help them. And part of the reason is because of the bad Omicron border, but also previous disasters of that kind. So that leads to some interesting ethical issues, I think. So one is this one that people often claim. They say, if we do find the next pandemic, we'll avert major global harms, and that would be great. And it would be so great that we should invest huge amounts of resources in doing that. What's kind of less often talked about is that if we identify an outbreak that wasn't actually going to become an epidemic or become a pandemic, then we're going to invoke major public health measures for something that wasn't ever going to spread in the first place. So it's going to be like futile suppression. And for some reason, that's disappeared behind my thing there. What does that say? Yeah, surveillance may probably trigger unnecessary suppression. And I'll talk about that in the next slide. Here's how it looks mathematically. If you suppose there's kind of 50,000 coronavirus spillover events and outbreaks per year, and suppose surveillance is really good, which it isn't, by the way, but let's suppose it is really good. It's 99% able to distinguish 99% between a kind of likely pandemic and an unlikely pandemic. Well, if it's 99% accurate, it probably will find the next pandemic out of that 50,000, provided that you detect all of those 50,000 outbreaks. And it will make, might make some judgments, might make the appropriate judgment to kind of suppress that pandemic. But it will also be used on the outbreaks that would have otherwise been self-terminating without public health intervention. And if it's 99% accurate, it will lead to around 500 false alarms. So there'll be suppression of 500 outbreaks or small epidemics that were never going to become pandemics. So that's a big cost to pay. You might think that it's worth it. One of the problems is that what it takes to suppress an epidemic is basically letting out the troops in poor countries. So here on the left is the Nipah virus outbreak in Kerala in India a couple of years ago, where previously responses to Nipah virus outbreaks were kind of old-fashioned public health, contact tracing, encouraging people to seek testing, no restrictive measures and so on. But now it's cordon sanitaire, that's what they're putting up there, blocking off the region, closing schools, lockdown and so on. This is from the Ebola, on the right, it's from the Ebola outbreak about kind of 10 years ago. What it takes to suppress an epidemic is major public health action at the source of that outbreak. And if we're doing that unnecessarily in 500 cases for every pandemic prevented, gosh, that's a big change in kind of global public health response. Now I'm going to just chat through some kind of interesting unresolved issues, although this is not an exhaustive list. One is this kind of distinction between research and public health. So sometimes when I talk to, well, often actually, when I talk to or submit papers on this topic and I get a kind of scientist or public health reviewer, they say there's no problem with the current system because it's very clear what's research and what's public health, and we have a system for research ethics and we have a system for public health ethics. But ultimately, it's not that clear. Public health research, one way people split it up is they say, well, the goal of research is to produce generalizable knowledge, whereas the goal of surveillance is to inform policy decisions. But of course, a lot of research also aims to inform policy decisions. Research generates new data, it involves human participants, and it requires ethics review. Whereas public health surveillance, the claim is that it, is primarily to inform policy, and generalizable knowledge is just a kind of side effect of collecting all these data on non-consenting human beings. But it doesn't require review, and there is no process for ethics review within public health agencies. It's basically if the boss of the public health agency thinks it's okay, then it's okay, as we discovered in Melbourne. But for people who are having their data collected, well, these activities can look pretty similar. And so it raises a question. One kind of question it raises is research. There's a perverse incentive here, right, for public health agencies to label an activity as surveillance because there's no, burden for them to get through research ethics review. So one lesson might be that research is overregulated. I think that's probably true, although the system is bad, which I think it is. Another implication might be that public health action is underregulated, which I think it is. And it's a question about, to what extent should these be harmonized or not. So I think it's an interesting unresolved issue. And there's multiple reasons why it's interesting, and unresolved. If you imagine we've got human health related data down the bottom and we're collecting it as a university and we're making it into academic outputs, we've got a simple pathway for that. In public health, like I mentioned, theoretically it's covered by public health ethics and the public health legislation or whatever, but in reality it's pretty messy. One thing that is really unclear is what the system should be for data sharing for health research. So in many cases, journals will just waive the ethics requirement for publication of public health data. In other cases, they'll require retrospective research ethics review. It's very inconsistent. And there's kind of two problems with that. One is that people are having their data collected without consent and then it's being used for research without oversight. Another is that the lack of clarity about the system there might mean that we miss out on knowledge benefits that we could gain by doing research, secondary research analyses on public health data in an ethical way. There is the reverse flow, so research data also used to inform public health, but that's usually a slower thing and it's already in the public domain, it's been covered by ethics, so it's less of a problem. There's a kind of side panel, which is that law enforcement and kind of legal cases might want to access health data, and they sometimes put pressure on public health agencies to share those data. It's less of a problem in Australia where there's, appropriate protections, although some of those protections disappear in a health emergency. But in countries, for example, where homosexuality is illegal, like Uganda, there could be pressure to release HIV data, for example, from law enforcement sometimes. And it's the kind of thing people worry about and want to protect. So there's lots of unresolved issues about how to handle data in this context. In Australia, I think there's some unresolved issues about what our policy should be. We've finally got ACDC, the Australian Centre for Disease Control. We've got really good global leading expertise in pathogen genomics. We've got pretty good public health system, at least in a disaster. There's a major overlap between clinical and public health and laboratory staff. That can be good because we can get things done quickly. It can also lead to these kind of uncertainties about who owns the data, what the appropriate uses might be. We've got limited use of restrictive interventions outside of an emergency context. And you would think that in Australia, we would have the potential for kind of novel data systems, federated data systems that would allow for kind of novel, AI-based surveillance and so on. But at the moment, I think it's very unclear, and there's not a lot of cooperation between the states to develop a kind of national system for public health surveillance, which is something that could be, this big gap that could be filled. So in conclusion, like I said, I'm trying to give a tour of the kind of what's new in public health surveillance. I think the benefits and harms are going to vary across different contexts and different surveillance data. But the background is that surveillance technologies have become much more accurate and they enable highly targeted interventions. It's no longer looking at just the population health level. It really does empower public health agencies to track individuals. And this occurs against a background where the norms for public health, for ethical use of public health data, really haven't been established. And the field of public health ethics, which got going in kind of the early 2000s, is still in its infancy and hasn't really been translated into policy in most places. So with that, I say thank you, and I'll welcome some questions.